1930s, the United States Public Health Service sent researchers into the mountains of eastern Kentucky to study a problem. The problem was not what they expected. They had gone to document the dangers of childbirth in medically isolated Appalachian communities to build the statistical case for replacing granny women with trained hospital obstetrics. What they found instead was that in certain hollow communities where granny women had practiced for decades, maternal mortality rates were comparable to, and in some documented cases lower than those recorded in urban hospitals during the same period. In 1930s American hospitals, puerperal fever was still claiming lives at rates that would be considered catastrophic by any modern standard. The granny women had no surgical suites, no intravenous antibiotics, no electronic fetal monitors. What they had was a system of knowledge developed through continuous practice across 2 centuries of attending births in the most geographically isolated communities in North America. A system so effective that when it was dismantled by licensing laws, hospital mandates, and systematic professional exclusion between the 1920s and the 1960s, the maternal and infant mortality statistics in those same communities moved in the wrong direction. The name granny woman described a role, not an age. She was the birth attendant, the first-line medical practitioner, the postpartum nurse, and the newborn assessor for her entire community, trained through years of apprenticeship under the woman who held the role before her. She carried no bag of instruments because she needed almost none. What she carried was in her hands, her eyes, and her accumulated understanding of every body she had ever attended. Before we start, hit subscribe. What you are about to hear is not a story about the past. It is a reckoning with what was taken, who took it, and what the statistics say about the cost. Let us count down. Number 20. Reading fetal position by hand. Leopold's maneuvers, the 4-step sequence of external abdominal palpation that maps the position, presentation, and engagement of the baby through the wall of the uterus, were published by a European physician in 1894. The granny women of Appalachia were performing equivalent assessments by hand long before that publication and without knowing his name, because knowing where the baby was positioned was the most fundamental piece of information a birth attendant needed. An experienced granny woman could determine fetal position, estimate fetal size, assess engagement in the pelvis, and identify abnormal presentations through touch alone. Modern midwifery researchers studying traditional birth attendants have consistently found this accuracy remarkable. This was not intuition. It was pattern recognition built from attending more births than most obstetricians manage in a full hospital career. Number 19. Identifying and managing a breech presentation. A breech baby, positioned feet or buttocks down rather than head down at delivery, is treated in modern obstetrics almost exclusively by cesarean section. In early Appalachia, cesarean was not an option. The granny women managed breech deliveries vaginally and knew the specific maneuvers for a frank breech, a footling breech, and a complete breech. They knew how to support the emerging body without pulling, how to deliver the aftercoming head, and how to manage the critical moments when the cord could be compressed. Some also practiced external cephalic version, the manual turning of a breech baby before labor, a technique that modern obstetrics reintroduced in the 1980s after decades of abandonment and now recommends as standard care. The granny women never stopped recommending it. They simply were not asked. Number 18. Managing a stalled labor without pharmaceutical intervention. Modern obstetrics responds to a stalled labor with ruptured membranes, synthetic oxytocin, and if neither works, cesarean. Each carries its own risk profile. The granny women use position changes, specifically moving a laboring woman from lying down to upright, squatting, or walking, to use gravity and pelvic movement to encourage the baby into better alignment. They use continuous emotional support, reducing the fear that causes the physiological stress response that measurably inhibits uterine contractions. A Cochrane review published in 2017 found that continuous support during labor reduced the likelihood of cesarean delivery by 25%. The granny women built that support into every birth they attended as a matter of course, not as an intervention but as the baseline expectation of their presence. Number 17. Recognizing and responding to cord prolapse. A prolapsed umbilical cord, descending through the cervix ahead of the baby, is a true obstetric emergency. The baby's body can compress the cord and cut off oxygen within minutes. Granny women were trained specifically to recognize its signs, to keep pressure off the cord using manual positioning, to place the mother in a position using gravity to reduce compression, and in some documented cases to physically hold the presenting part off the cord while the fastest available transportation was arranged. They knew which emergency required transfer and which required management in place, and that discrimination, knowing the precise boundary of their own competence and acting on it without hesitation, was as sophisticated as any clinical decision-making protocol modern obstetrics has formalized. Number 16. Assessing the newborn at birth. The APGAR score, the standardized system for assessing a newborn's condition at 1 and 5 minutes after birth, was developed by Virginia APGAR and published in 1952. Before 1952, there was no standardized tool. What there was in every mountain cabin and every delivery room was an experienced attendant who knew what a healthy newborn looked, sounded, and felt like. The granny women assessed newborn color, muscle tone, respiratory effort, and cry quality within the first moments of birth. They knew to stimulate a slow-to-breathe baby by rubbing the back to clear the airway, to keep the newborn warm against the mother's body. The APGAR score gave a number to what the granny women were already observing. It did not create the observation. It standardized it for an institution that required documentation. Here is the data point the medical establishment of the early 20th century preferred not to examine too carefully. In 1933, the White House Conference on Child Health and Protection published a report finding American maternal mortality rates among the highest in the industrialized world, concentrated in hospital deliveries, and specifically linked to physician-attended births where infection rates were dramatically higher than in midwife-attended births. The data was there. Granny women and lay midwives attending births at home, with careful hand hygiene practices, were in many documented cases producing better outcomes than hospital deliveries in an era when hospital infection control was still inconsistent. This was not because hospitals were bad. It was because the granny women had developed practices calibrated to their environment over 2 centuries, and those practices worked. The report did not conclude that midwives should replace physicians. The political environment made that conclusion professionally impossible. But the numbers said what the report would not. Number 15. Managing postpartum hemorrhage. Hemorrhage after delivery is the leading cause of maternal death worldwide and has been for the entire recorded history of childbirth. Postpartum hemorrhage management was among the most carefully transmitted pieces of granny woman practice because the consequences of failing at it were immediate and absolute. They used uterine massage, the firm external manipulation of the uterus to stimulate contraction and reduce bleeding, a technique that modern obstetrics still uses as a first-line response. They used partridgeberry, a low-growing woodland plant of the Appalachian forest floor also called squaw vine, administered during the final weeks of pregnancy to prepare the uterus for efficient postpartum contraction. They used shepherd's purse, a common plant with documented hemostatic effects on uterine bleeding. Neither plant has appeared in any previous video on this channel. Both were used with precision developed through generations of observation of what reduced bleeding and what did not. Number 14. Managing preeclampsia and eclamptic seizures. The signs of preeclampsia, sudden severe swelling of the face and hands, headache unlike any the woman had experienced before, visual disturbances, were recognized by granny women as danger signals requiring immediate action long before the underlying physiology was understood by anyone. When a woman seized during labor, the granny woman's response, turning her to her side to protect the airway, preventing injury, waiting for the seizure to resolve, and arranging transfer if possible, mirrors the immediate management protocol still taught in modern obstetric emergency training. They could not stop the seizure pharmacologically. They could prevent the most common causes of death from it, aspiration and physical injury with correct positioning and continuous attendance. Number 13. Establishing breastfeeding and managing the postpartum period. The granny woman's role did not end at delivery of the placenta. She returned daily for the lying-in period, typically 10 days to 2 weeks following birth, to monitor mother and infant, support breastfeeding establishment, and identify infection early. Modern research consistently finds that continuous skilled support in the immediate postpartum period is the strongest predictor of successful breastfeeding initiation and duration. The granny woman provided exactly this. She knew how to assess a proper latch, how to address engorgement, how to identify mastitis before it became abscess. Modern lactation, consulting as a profession, was created to provide a service The granny woman provided as a standard component of every birth she attended. Number 12. Caring for a premature newborn without technology. A premature infant born in a mountain hollow in 1925 had no access to an incubator, no supplemental oxygen, no feeding tube. The granny woman's response was to keep the infant continuously against an adult body for warmth, feeding it in small, frequent amounts. This practice, now called kangaroo mother care, is formally endorsed by the World Health Organization as an evidence-based intervention that reduces premature infant mortality by 40% compared to incubator care in low-resource settings. The huge recommendation was published in 2003. The practice it recommends is as old as premature birth itself. The granny women did not know the mechanism. They knew the outcome, and they passed it forward. Here is the legislative history that nursing textbooks tend to skip. The Shepherd-Towner Maternity and Infancy Protection Act, passed in 1921, was the first federal health legislation in American history. It funded public health nurses, maternal health clinics, and in several states, the training and registration of lay midwives, bringing granny women into a regulated system while preserving their practice. The American Medical Association opposed it from its inception, lobbying aggressively against it as government interference in medicine and as implicit endorsement of what they called unqualified competition. By 1929, the AMA had succeeded in blocking its renewal. The federal funding ended. State-level licensing laws that followed in subsequent decades did not replace the federal program with something equivalent. They replaced it with requirements that effectively criminalized the practice of women who had no access to the formal education the licenses required. The granny women were not replaced by something better. In many communities, they were replaced by nothing at all. Number 11. Turning a malpositioned baby during labor. Malposition during labor, when the baby's head is in an unfavorable angle relative to the birth canal, is responsible for a significant proportion of prolonged labors and cesarean deliveries in modern obstetrics. Granny women use specific maternal positioning techniques to encourage rotation during active labor. Hands and knees positioning creates more room in the posterior pelvis, facilitating rotation of a baby facing the wrong direction. Side lying with the upper knee raised promotes specific patterns of rotation. Modern research on optimal fetal positioning has arrived at essentially the same recommendations through randomized controlled trials that the granny women arrived at through 2 centuries of empirical observation. The technique did not change. The publication data the confirming study did. Number 10. Managing twin deliveries. Twins occur in approximately 1 in 80 pregnancies. Twin delivery is among the highest-risk birth scenarios because of the potential for the second twin to be in an unfavorable position after the first is delivered, for placental separation between deliveries, and for the interval between births to extend dangerously. The granny women were trained specifically in twin management. They knew how to assess the second twin's position after the first birth and how to recognize when the situation had exceeded what they could manage safely. The knowledge that a twin delivery required the same attendant to stay through both births, no matter how long it took, sounds obvious. In an era of shift-based hospital care, it is actually a logistical problem that modern obstetrics has not fully resolved. Number 9. Blue cohosh in labor support. Blue cohosh, a plant of the Appalachian forest floor unrelated to black cohosh, despite the similar name, has not appeared in any previous video on this channel. Granny women used it in carefully managed small amounts during labor to strengthen contractions that were weakening or becoming irregular. The plant contains compounds called calosaponin and calophyllosauponin that have demonstrated uterine-stimulating activity in laboratory studies. It was dismissed as dangerous folk medicine by the medical establishment that displaced the granny women who used it. It remains controversial in modern herbalism precisely because its compounds are physiologically active, which is to say it is controversial for exactly the same reason it was useful. The precision with which it was applied, small amounts, late labor, specific presentations, represented clinical judgment built through decades of supervised practice. Number 8. Perineal support and preventing tearing. Modern evidence on episiotomy is now clear. Routine surgical cutting before tearing occurs does not prevent severe tearing and increases overall tissue damage compared to watchful waiting with manual support. This conclusion, formally established in the obstetric literature in the 1990s and 2000s, is what the granny women practiced as a matter of course for 2 centuries. Warm compresses applied to the perineum during pushing, slow controlled delivery of the head with manual counterpressure, coaching the laboring woman to breathe rather than push hard during crowning. These are precisely the techniques that modern evidence-based midwifery now recommends. The granny women never had episiotomy scissors. They used the techniques available. The techniques available turned out to be the right ones. Here is the testimony that matters most in this history. Annie Lee Logan, a black granny woman from Alabama who practiced for decades in rural communities with almost no hospital access, documented her own practice in a memoir published in 1989. Logan described delivering more than 1,000 babies over her career with a maternal mortality rate that the fragmentary records available suggest was lower than the regional hospital rate for black mothers during the same period. She described reading a laboring woman's body the way a mechanic reads an engine, through sound and feeling and the timing and quality of contractions. She described knowing within minutes of arrival at a birth whether it would be simple or complicated, not through intuition but through pattern recognition, built across a career of continuous practice. She trained apprentices and insisted on it. When she could no longer attend births herself, she spent her remaining years trying to ensure that what she knew would not die with her. The licensing laws that made her practice technically illegal did not stop her from practicing. They stopped the next generation from learning. Number 7. Reading the placenta after delivery. The placenta is examined after delivery in modern obstetrics to confirm it has been delivered completely, because retained fragments cause hemorrhage and infection. The granny women performed this examination by hand and by inspection with a thoroughness that surprised modern researchers who studied their practices. They knew what a complete placenta looked like, knew how to assess the membranes for completeness, and knew that a placenta that did not look right meant a mother who needed watching. They also used the placenta diagnostically, observing its condition to assess the health of the pregnancy just concluded. This practice is now the subject of growing interest in placental pathology research. The granny women were reading a document that medicine is only now learning to fully interpret. Number 6. The apprenticeship system. A granny woman did not become one by completing a course or passing an examination. She became one by spending years attending births under the supervision of the woman who held the role before her, first as an observer, then as an assistant, then as primary attendant with her mentor present, and finally alone. This progression took as long as it needed to, typically between 5 and 15 years of continuous practice, ending only when the mentor judged the apprentice ready. This is the most rigorous form of clinical training available and is the model on which modern surgical residency is based. The licensing laws that displaced the granny women did not require an equivalent depth of supervised clinical experience. They required written examinations and formal credentials that the granny women had no access to, and that tested theoretical knowledge rather than demonstrated clinical competence. Number 5. Continuous presence through labor. A laboring woman attended by a granny woman was never alone. The granny woman arrived when labor began and stayed until mother and baby were stable. In a hospital labor and delivery unit today, a laboring woman is typically monitored by nursing staff rotating through multiple patients simultaneously. The Cochrane Review on Continuous Support in Labor, covering 26 trials involving more than 15,000 women, found that women who received continuous one-on-one support were 25% less likely to have a cesarean delivery, 31% less likely to use pain medication, and had significantly shorter labors. The granny women provided what this research describes as the most effective labor intervention available. They provided it to every woman they attended, not as a premium service, but as the only way they knew to attend a birth. Number 4. Knowing when to transfer. The most sophisticated clinical judgment a birth attendant makes is recognizing the moment when what is happening has exceeded the boundary of what can be safely managed in the current setting. For granny women, transfer often meant hours of travel over unpaved roads by wagon. The decision required accurate early recognition of a deteriorating situation, because by the time a complication was obvious, the transfer window might have closed. Granny women were trained specifically in the warning signs that preceded catastrophe: the quality of bleeding indicating placental abruption, the face and reflexes of a woman approaching a eclamptic seizure, the fetal heart sounds indicating cord compression. They knew these signs because the women who trained them had seen them in an unbroken chain of transmitted clinical observations stretching back to the earliest settlement of the mountains. Number 3. Infection prevention without germ theory. Puerperal fever, the streptococcal infection of the uterine lining following delivery, was the most common cause of maternal death in the 19th and early 20th centuries. In hospitals, it spread on the unwashed hands of physicians moving from patient to patient. Semmelweis demonstrated in 1847 that hand washing with chlorinated lime solution reduced puerperal fever mortality from 10% to 1%. The medical establishment rejected his findings for 2 decades. Meanwhile, the granny women with no knowledge of germ theory were practicing meticulous cleanliness at every birth because they had observed across generations that unclean hands led to mothers who sickened and died. They boiled their instruments. They washed their hands before every internal examination. They were practicing infection control before the concept had a name because they had watched what happened when they did not. Number 2. The statistical reckoning after their removal. Between 1930 and 1970, the proportion of births attended by lay midwives in the United States fell from approximately 15% to less than 1% as hospital birth became universal and licensing laws made lay midwifery effectively illegal in most jurisdictions. This transition was presented as straightforward progress. The statistics tell a more complicated story. In rural Appalachian counties where granny women had practiced, the transition to hospital birth required women to travel distances that made timely arrival uncertain. The continuous support of the birth process disappeared. The postpartum visiting that identified infections and breastfeeding failures in their earliest stages ended. The maternal mortality statistics for rural Appalachian communities in the decades following this transition do not show the dramatic improvement that the narrative of progress predicts. In some documented counties, they moved in the wrong direction before gradually improving as hospital access itself improved decades later. The granny women were not replaced by something better. In many communities, they were replaced by a long drive on a bad road. And number 1, Annie Lee Logan's last class. Near the end of her life, Logan sat with researcher Catherine Clark and spoke for months about everything she knew. The memoir that resulted, Motherwit, published in 1989, is the most complete first-person account of granny woman practice in existence. In it, Logan describes not the romance of traditional birth, but the clinical reality of it, the sweat of a long labor, the weight of a decision made in the dark without a telephone, the sound of a newborn who was not crying correctly and what you did about it. She describes training her last apprentice and the grief of knowing that licensing laws made it impossible for that apprentice to practice legally what Logan had spent 40 years learning. She does not claim to have been better than a hospital. She claims to have been what was there, to have been present when presence was the only thing available, and to have made that presence count with everything she knew. The knowledge she carried died without a full institutional successor. The licensing laws that made her illegal did not create the infrastructure to replace her. They made her stop. In the communities that depended on her, and on thousands of women like her across 2 centuries of Appalachian birth, the stopping was not a medical event. It was a loss that the infant and maternal mortality statistics of the following decades recorded without sentiment and without acknowledgement of what had been taken. Here is my challenge. Find out if anyone in your family was born at home with the help of a granny woman or a lay midwife. Ask the oldest family member you can reach. Then come back and tell me what you learned in the comments. The number of people watching this video whose existence traces back to a granny woman's hands is larger than any of us have been told to imagine. That knowledge was not replaced because it failed. It was made illegal because it worked for free. The statistics know the difference even when the history books do not.